When I start patients on a prostaglandin analog, I often tell them that their eyelashes can get longer over time. Their iris and eyelids can also get darker, almost like a mascara eyeshadow effect. The eyes may get red, and sometimes the eyes can even have more of a bit sunken-in appearance. These changes may happen within weeks, but they can be reversible after stopping the medication. Prolonged use over years may leave some permanent changes. Prostaglandins can also worsen or reactivate previous inflammation, such as uveitis or hepatic keratitis, or even cause cystoid macular edema. Rarely, there can be side effects outside of the eye, such as flu-like symptoms with headaches, muscle and joint pains. Because of the appearance-related side effects, I typically do not prescribe a prostaglandin if patient needs treatment only on one side. In my experience, patients who wear glasses are not as concerned about the pigment changes to their eyes, but those who don't wear glasses are more aware and sensitive to the appearance changes. For patients who have arthritis in their fingers and have a hard time squeezing the eye drop bottles, I encourage them to buy these commercially available devices that can be placed onto the eye drop bottles and make them ergonomically easier to apply the drops. After starting treatment, unless the pressures are very high, I usually ask patients to come back for follow-up in about a month. I do, however, advise patients to contact our office if there is any concerning side effects. I also encourage patients to take pictures with their cell phones, particularly if the hyperemia or appearance-related side effects tend to be transient. It is important to identify whether the side effect is related to the prostaglandin only, or if it can be related to the preservative such as benzalkonium chloride, also known as BAK. For instance, if a patient experiences hyperemia, we should find out whether it is conjunctival hyperemia only, or if it is due to ocular surface disease like tear film dysfunction. Checking tear breakup time with fluorescein can be very helpful. If ocular surface disease is the main cause, one may consider treating with artificial tears first, before stopping the prostaglandin or switching to preservative-free alternatives. If a patient truly cannot tolerate the prostaglandin, then I would stop it and use medication from another class, or consider procedural alternatives. If there's cystoid macular edema caused by the prostaglandin, most of the time after stopping the prostaglandin and starting patient on a topical non-steroidal anti-inflammatory drop, the edema would resolve.